Hello everyone and welcome to this RPTH research recap where we dive a little deeper into the science being published at RPTH. My name's Lara Roberts, I'm a consultant haematologist at King's College Hospital and the clinical lead for venous thromboembolism. My clinical and research interests include venous thromboembolism and hemostasis and liver disease, and I also serve as an associate editor at RPTH. I'm delighted to introduce Thijs van Hups, MD, a Netherlands-based researcher. Thijs's research addresses the use and reversal of anticoagulation in clinically challenging contexts, such as during the COVID-19 pandemic, as well as in patients with altered gastrointestinal anatomy, such as those after bariatric surgery or with short bowel syndrome. He currently works as a resident in obstetrics and gynecology in the Netherlands. Thijs recently published a paper in RPTH titled Andexanet alfa for the reversal of low molecular weight heparin and enoxaparin. For those of you joining us live, please leave your comments and questions in the chat and we'll answer those during the discussion. Thijs, I'll hand over to you. We're looking forward to hearing your presentation.
Yes, I hope you can see my slides now. Thank you, Lara, for that great introduction, and thank you for presenting our recently published paper, as you just said, in RPTH. Here you can see my name and, of course, all the other co-authors we did this project with. So to start off, I have no personal disclosure to make. However, this study was funded by AstraZeneca. And hopefully, after this presentation, you can all recognize the need and clinical dilemma in the reversal of anticoagulation in patients with acute major bleeding, interpret the similarities we see between the effects of Andexanet alpha on direct versus indirect factor Xa inhibitors, and also describe the effects of Andexanet on those indirect factor Xa inhibitors. But to start off, I would like to sketch you all the picture we currently have over the coming years. And it is that since the introduction of the DOACs, the factor 2A inhibitor, dabigatran, and the factor 10A inhibitor, apixaban, rivaroxaban, and edoxaban, we've seen a huge shift from the conventional use to vitamin K antagonists. And currently we see that in the Western population, almost 80 to 90% of the patients who have an indication for anticoagulation, for example, as treatment or secondary prevention of venous thromboembolism, or as prevention in patients with atrial fibrillation, are treated with a DOAC. And just to remind you all, is when we compared the vitamin K antagonist to the DOAC in the three major registration studies, the Einstein, Amplify, and Hokusai, we saw that it had similar effectiveness. However, there is no clinical need for drug monitoring compared to the vitamin K antagonist. And what we saw is that there was a lower risk of major bleeding events in the patients treated with the DOAC. And to remind you all and also sketch the picture is why we would use reversal therapy. Just to remind you all, is we take a look at the major bleeding criteria provided by the ICH. That criteria says that a bleeding event is called major if it's a fatal bleeding event, a symptomatic bleeding event in a critical area of organ, or if it results in a drop of hemoglobin level of over 20 grams per liter, or leads up to 2 or more blood transfusion. And if we then take a look at what the consequences could be of a major bleeding event, we see that if we take a look at the mortality rate, we see that intracranial major bleeding events have a mortality rate associated with 45 to 50%. And extracranial major bleeding events, which are mostly defined by the gastrointestinal bleeding, have a mortality rate of 4 to 6%. And as you can see, these two bleeding events are both classified according to the ICH criteria and are classified as a major bleeding event, but there's a huge heterogeneity in their clinical outcomes. And therefore, it's also good to take a look at those bleeding events in a different way. And that was done by my colleague Blaker et al. In 2017. And here they assessed the bleeding according to a new scale, which was called the bleeding severity scale. And in that scale, the bleeding events are characterized in 1 to 4 categories. in which category 1 results in a non-life-threatening bleeding, and the last category is category 4, in which the patient has already been deceased, or if death is inevitable. And if we classified the bleeding events we saw in those previously mentioned major registration trial, we see that 40 and 41% of those bleeding events can be classified as a category 2 and 3. And those are exactly the bleeding events you would like to target with the reversal agent. So we actually do this research for those patients. And in that case, it is always important, if we take a look at reversal therapy, that we don't lose focus on what we're looking at. So it's extremely important to study if there is an immediate removal of the anticoagulation and an immediate restoration of the functional hemostasis we saw before the anticoagulation was administered. And in that light, we should also aim to improve the patient's outcome of the bleeding without inducing any thrombotic complications. And that actually leads us to three crucial questions we see and should answer in all reversal studies. And that is mainly, does it reverse the anticoagulation effects? Is that seen in any laboratory outcome? What is the functional outcome of the major bleeding events in patients? And what is also the risk of thrombotic complications? And that actually brings me to one of the reversal therapies that is currently available, and that is called Andexanet alfa. And I'm sure you all heard about it, but to remind you all, Andexanet alfa is a decoy factor 10A molecule. However, it lacks the so-called GLA domain, and therefore it cannot form a prothrombinase complex. And that should be the reason that any thrombotic complications should be limited. And this drug was approved after the results from the Annexa-4 study. And in that study, there was in total over 450 patients with a major bleeding event and the use of factor 10A inhibitor. And there we saw that over 90% of reduction in anti-10A activity was measured. We saw a great proportion of patients who achieved good or excellent hemostatic efficacy at 12 hours. And we also saw 10% rate of thrombotic events at day 30 and 60% of mortality rate. And currently, Andexanet is not registered for the reversal of indirect factor 10 inhibitors. However, in our study, we had the following hypothesis. And as you probably also know, the drugs low molecular weight heparin are also indirect factor 10A inhibitors, and that is via their binding to antithrombin. And when factor 10A then enters the picture, that binds to the complex of low molecular weight heparin and antithrombin. However, when we then introduce Andexanet, this binds with high affinity towards this antithrombin complex, and therefore it should reverse the effect of the factor 10A inhibition and should restore hemostasis. And that's exactly what we aim to show in this study. So we wanted to show the effects of Andexanet in patients treated with indirect factor 10A inhibitors on two levels. First, we want to show it on biomarkers, and therefore we chose the anti-10A activity and thrombin generation. And for this, we used healthy volunteers. And next, we also wanted to look at it in the clinical outcomes of patients with acute major bleeding. And for that, a subset of patients who were treated with enoxaparin in the Annexa-4 study was used. So to start off, in so-called part 1, we see the healthy volunteer study. And this was a double-blind randomized healthy volunteer study in which all patients were dosed to steady-state enoxaparin and afterwards were randomized to receive Andexanet at a high-dose regimen after the 3 hours last dose of enoxaparin, Andexanet low dose, which was given 8 hours after the last dose of enoxaparin, or placebo. And these regimens were chosen in order to further align with the methods which were used in the Annexa-4 study. So to start off, if we then take a look, in total 21 healthy volunteers were included, of which 16 were allocated to the high dose regimen and 15 to the low dose. And as you can see in the slides, on the y-axis you can see the anti-10A activity, and on the x-axis the corresponding time since administration. And here we can clearly see, if we take a look at the lines, that there is a decrease in anti-TNA activity when we compare the levels with Andexanet given patients and placebo. And to further study, as I just said, we also took a look at the thrombin generation. And again, this is a busy slide, but here you can see on the x-axis the time since administration, and on the y-axis the corresponding endogenous thrombin potential level. And in order to further say something about that hemostatic efficacy, you can also see that for this study group, we determined a so-called pre-anticoagulant state, and that was measured 4 days prior to enoxaparin. And you can see those levels back in the slides, in light gray with the mean with 1 standard deviation, and in darker gray with the mean with 2 standard deviation. And if we then take a look at the rate of the endogenous thrombin potential over time, we can see that after the end of infusion, there's a restoration towards that so-called normal pre-anticoagulant state we measured prior to enoxaparin dosing. So now to go to the proof of the pudding, the state of the clinical patients. You probably all know the Annexa-4 study and how this study was performed. But just here as a small reminder, in Annexa-4 patients with acute major bleeding who met the inclusion criteria were included when the last dose of the factor Xa inhibitor was within 18 hours. And patients also received an IV bolus followed by a transfusion. And during the change in anti-10A activity was measured, and the hemostatic efficacy was determined at 12 hours after the IV bolus. And next, as safety measurements, both thrombotic events and 30-day mortality was collected. And of those 479 patients who were included, 22 patients were treated with enoxaparin. And if we then first take a look at those 22 patients, we can see that the mostly used indication for anticoagulation was for venous thromboembolism, followed by atrial fibrillation. And the primary site of bleeding was intracranial, followed by gastrointestinal bleeding. And again, here we can see that there is a decrease in anti-10A activity towards 75% at the end of bolus. And also, we took a look at the endogenous thrombin potential. And again, as you can see, that there is a restoration towards a level which was above the, which was higher than before the Andexanet was started. And if we then take a look at the clinical outcomes which were collected at 30 days, in total 22 patients were included in the safety population, of which later on 16 were allocated to the efficacy population. And this efficacy population were patients who actually had a confirmed major bleeding event, and in which also a baseline anti-10A activity was below 0.25 international unit per milliliter, which suggests that there was currently active factor Xa inhibitor. And if we then take a look at the effective hemostasis, we can see that over 80% of the patients had effective hemostasis, and there was thrombotic complication of 5%, combined with a safety measurement of mortality of 9%. So to summarize these results, if we take a look at the use of Andexanet alpha in indirect factor Xa inhibitors, namely enoxaparin, we can see that on biomarkers there is an immediate and large reduction in anti-10A activity, which shows a partial rebound after the end of infusion. And if we take a look at the thrombin generation, we can see that this increases and normalizes to a so-called pre-anticoagulant state. And to then take a look at the proof of the pudding, we can see that over 80% of these patients with acute major bleeding who are also treated with enoxaparin and now with Andexanet show good or excellent hemostatic efficacy. And these suggest that these results are fully in line with the previous published results of the use of Andexanet in apixaban and rivaroxaban. Still, some limitations have to be made. First of all, only a modest number of patients who were treated with enoxaparin were included in this analysis. Next, one of the exclusion criteria of the Annexa-4 is that they excluded patients who had an intracranial hemorrhage with a Glasgow Coma scale below 7 or with a large hematoma volume. this could have impacted any improvement we see in the hemostatic efficacy, but one could also wonder if these patients would later on be treated with any reversal agents, since their outcome is not that great. Next, and lastly, the Annexa-4 was a single group study with no comparator. Still, if we take a look at the currently published Annexa-I, we can question whether any randomized control trial with low molecular weight associated major bleeding could be feasible. And lastly, there's also still a debate on what we would compare Annexa of Andexanet in that case with, and if protamine, for example, would be a viable comparator. So to conclude, what we saw in this study is that Andexanet showed similar efficacy for reversal of the low molecular weight heparin enoxaparin as was previously observed in rivaroxaban and apixaban. Still, any regulatory approval would need much larger clinical studies in patients with major bleeding. And also in that case, any effectiveness should be assessed with other low molecular weight heparins and also, for example, fondaparinux in order to further say anything about the reversal of Andexanet in their RACT factor 10A inhibitors. Lastly, I would like to, and all the authors would like to acknowledge late Dr. Stuart Connolly, who was the principal investigator for the Annexa-4 and Annexa-I clinical trials. Any questions?
Excellent presentation. I will now open the webinar up for questions, so please type these in the Q&A box and we'll try and get through as many as we can. Perhaps I'll start things off by asking whether this study has changed your clinical practice. What's your real world experience of using Andexanet?
Yeah, that's an excellent question. Yeah. As you also stated, I'm still, currently I'm doing my first clinical job. So my experience with Andexanet in practice is really limited. I've only seen it used in any study inclusion of the Annexa-4 study. But not, also in the Netherlands, it's not daily practice we use this. Often PCC, so protein complex concentrate, is used when we see these patients, but it depends.
Okay. The other thing that I noticed was that the mean time from the dose of enoxaparin to Andexanet was 12.5 hours.
Yeah.
And often in clinical practice, as a clinician, I think, oh, it's more than 12 hours, not going to be much activity, I'm not going to give them protamine. But the detectable activity in your study was actually still quite high. I think it was 0.48. So do you think maybe we're too conservative in offering reversal to patients on low molecular weight heparin? Do you think we should be a bit more liberal in offering protamine where we're using that?
Yeah, I guess it depends always on the clinical picture you see. I mean, if there is a huge active bleeding, then you can also maybe in some cases start earlier on. But indeed, I guess more research should be performed to see whether this is something we only see in this patient or only saw in this patient. I'm currently not aware that there are any studies who only take a look at the anti-10A activity after 12 hours of presentation. As you just stated, it's normally much sooner we see these patients. But indeed, that is one of the observations we also saw and thought, should we do something with that in later clinical practice?
Thank you. There's a couple of questions in the chat now asking about the costs, particularly in comparison to protamine.
Yeah, that's always the huge debate about Andexanet. I completely agree. It's a hard picture to make, especially if we want to give this medicine to all over the world. The costs are high, and it really makes you question whether this could affect its use. But I don't know anything about the cost. That's not my my cup of tea.
I think in the UK, protamine is about 6 or 7 pounds, and Andexanet, I think for the high dose, is approaching 20,000.
Yeah, that's also
So,
we see in Holland. Yeah,
yeah,
it's a huge
quite a big
difference.
difference.
Yeah.
And there's another question here. Would your observations also apply to fondaparinux? Because I guess we don't have a reversal agent at all for fondaparinux.
No, exactly, and that is as I tried to state it in the last slides. It could be, but it's a completely different drug. We didn't test it here. I'm also not aware that currently AstraZeneca is planning to test it in fondaparinux or any other study group currently. But there could be how do you say, like an overlap. But in that I'm not completely sure. We need to make not too hasty decisions and conclusions from only these 22 patients. I think we need to be modest in these results.
There's another question asking whether there's any data for patients with a low antithrombin. So I guess that's kind of getting at a heparin resistance, but I'm not sure whether that would impact on efficacy of the reversal. I don't think you measured antithrombin, did you?
No, we didn't in this study. No. I'm thinking again. No, sorry.
And there's a final question here. Is it relevant just as an option rather than as used for, I guess, rather than using for everyone, would you use it for selected patients?
Yeah, I guess that's an exact, that is an ideal question. I mean, I wouldn't say use this in every patient you see with an acute major bleeding, which is associated with a direct oral anticoagulant. Like more if the states are high. But then again, as we also spoke in the introduction, currently Andexanet is not given anymore in the United States. So also time will tell if maybe what the things will happen with Andexanet. It could be that it only goes currently to research, but we'll see that.
And perhaps I'll just finish with one last question. In this sub-study, the rate of thrombosis was relatively low, but there was higher rates reported in the later study with
Andexanet.
Did you want to comment on that? I think you allude to the mechanisms in the paper itself, but perhaps just for the audience, you could explain that a little.
Yeah, so in the Andexanet paper, there was indeed, they met the so-called preterm analysis, which was defined by the outcome, and that was a combined primary outcome, which also included, and now I need to say it correctly, sorry, I don't have it completely sharp in my head anymore, but mostly the primary outcome was not met by like improvement on hemostatic efficacy. So I'm not sure if the thrombotic complications we see there are also a bit clouded that the study ended before we would see any clinical improvements, which was also suggested as a primary outcome. Not sure if I'm being clear. I don't think so. Sorry.
It's okay. All right. Well, thank you very much for sharing your work with us, and to all of the audience for joining and taking part in the discussion. I'll bring this session to a close and just encourage everyone to look on the RPTH website for other recap webinars. Thanks very much.